Neither the El Paso Medical Society, its members, nor PBS El Paso shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
There is much cause for optimism in the world of prostate cancer. It's definitely one of the cancers, like breast cancer 20 years ago, there's something new every year. That's happening with prostate cancer and has been for the last 10 years or so. We're going to be talking to two doctors who are experts, and this is a live program. So if you want to call this evening, give us a call. We've got the medical students answering the questions, but the telephone number, 881-0013. We are also streaming live on YouTube, and that number is going to come up on your screen several times. So again, a live program, call with your questions, 881-0013. This evening's program is underwritten by Rio Grande Urology, and we also want to thank the Texas Tech Paul F. Foster School of Medicine for providing the medical students for manning our phones. We have with us today Isa and also Ratika, and they are both second years in medical school. And usually we get the first year, so I don't know what you guys did to get the slot, so way to go. Very much appreciate you being here. And what Isa and Ratika are going to do, they're going to be texting me your questions. So when you see me on the phone, it's not that I'm talking to my teenage kids or anything. I'm actually getting the questions from you, the audience, so we can bring them here to our doctors. I also want to say a huge thank you to the El Paso County Medical Society. They've been doing this program for over 23 years now. And again, it's the El Paso Physician. The first show we ever did was a prostate cancer show, and we'll talk about that in a moment too. I'm Catherine Berg, and you're watching the El Paso Physician. Thanks again for joining us. It's Prostate Cancer Month, September. It's a month of everything, but this is a month I remember 23 years ago, and I was talking about that. When I was working at the American Cancer Society, Travis's mom, Dr. Mendal's mom, knows me from those days, but my very first show of doing anything in the medical community was the prostate cancer show, and I believe Dr. Vogelweed was one of the doctors on that show. And for those of you that remember a lot of these docs, we also used to have Dr. Horowitz and Dr. Chesbro. So it's been a long time coming, and I look forward to coming back to a prostate cancer show every year because there's always something brand new that I learn. So right here to my left, we have Dr. Daniel Vogelweed, who is a urologist. And then to my left, we have Dr. Travis Mendel, who is a radiation oncologist. I'm sorry? Oh, you're my right, left. I'm a pilot, so I'm allowed to say that, right? People say I get those mixed up all the time. So to my right, Dr. Vogelweed, at least that right. It could be stage left. As a urologist, I mean, you do a lot of things. It's male and female, but obviously tonight we're going to be talking about prostate cancer. So in your discipline, what is it that you do all day, every day, so that when questions do start coming in from the audience, we know who to direct them to?
If we're referring to prostate cancer,
yeah, that's...
You know, I mean, I'm a general urologist, but I do have, I'm going to call it a subspecialization in advanced prostate cancer. And for the group, our group, I manage the medical side of the advanced prostate cancer.
Okay.
And I run that clinic. As far as prostate cancer is concerned, you know, everybody in the group initially makes a diagnosis and decides what the treatment's going to be. Once that cancer has been treated and it comes back, or if it presents in an advanced stage, then they usually get referred to me.
Okay. And so in your group, how many people do you have in the group?
About
how many
12,
doctors? Okay.
about 12
okay.
or 13,
okay.
something like that. I always lose count.
Yeah.
There are 3 in Las Cruces. There are four in my office, including a pediatric urologist.
Okay.
Travis goes back and forth. There's 2 that go back between downtown and the east side, and there are 4 on the east side,
okay.
which 3 of those 4 go back and forth.
Nice. So it's a good number, and you're all over the place, and I love that, and I think that's great for our community as well. Dr. Mendal's just fun. Radiation oncology. So what I would like to do, and I know this is almost too simple, there's a radiologist and a radiation oncologist. I want you to first differentiate between the two, because sometimes people really get those mixed up, and we also want to give you your due in really studying and doing what you do. So first separate those two, and then talk about what your role is all day, every day.
Perfect. So radiology is a completely separate specialty from radiation oncology. And so the radiologist They review MRIs, CT scans, chest x-rays in a dark room with these very expensive monitors, and then they give reads. And so those are the people that basically look at the pictures in the medical field and then make diagnosis off that, or recommendations, or what have you. With radiation oncology, what we do is we use radiation, external beam radiation, another type called brachytherapy, where we insert either radioactive seeds or catheters that we can deliver radiation from the inside out. So we use radiation as a therapeutic to treat cancer. And so basically my day consists of seeing essentially solely cancer patients. And so I have a regular clinic, just like you usually would with a doctor, where you come in, see me in the office, I evaluate you for different treatment options. In the background, there's between 30 and 50 patients being treated on the radiation machines that we have, procedures happening, and then planning going on. And it's a very, very team-centric specialty where I have a physicist, Dr. Ume, we have a dosimetrist, we have therapists. It's a very big team, and I'm now the captain of it.
Now you're the captain of the team. And I was talking, you look like you're 12 years old, but you're a whopping 32. I'm allowed to say that. I'm 53 and I'm not going to ask your age. What I'd like to do, 27.
Backwards.
Good. Really? Good for you.
Yes.
Way to go. You look great and healthy.
Thank you.
What I'd like to do is kind of have the audience look at you as surgery man and you're gadget man. Often when I do oncology shows, I talk with radiation oncologists and it's like they get excited because there's new toys every couple of years and new ways of doing beams and special beams. But I feel like of all cancers that are out there, prostate cancer is probably the most specific, individualized treatment that can be done out there. So on that note, Dr. Vogelweed, what I'd like to do is, actually I'm going to back up. I know that we have a graphic of the prostate area, and so I'd really like to explain that to the audience first so that as we are talking through, we can kind of get an idea of what that is. So if we can get the folks in back row, see if we can pop that up onto the screen, and Dr. Vogel, we will talk through what that graphic is. And maybe it's up and I'm just not seeing on our monitor, and if so, somebody yell at me and jump up and down. If not, we can let's just walk through. I know we don't have the graphic up. Is it up to the people at home? Or we can, no? Okay, so let's talk about where the prostate is located. So when there is screenings, there's the digital rectal exam. So when a doctor goes in through the rectal area, where are you trying to feel for the prostate and what are you feeling for? And if we're able to get the graphic up, we'll get that up.
Okay, the prostate gland, if you can imagine a balloon that your small child plays with, that balloon represents the bladder. And then the neck of the balloon is the urethra. Well, the prostate sits right around the neck of the balloon. And you can usually feel the back portion of the prostate. Yeah, you can see it on that picture, and you can actually see the back portion of the prostate. You can feel when you do the rectal exam.
Okay.
And when you're doing that rectal exam, what you're checking for is the consistency of the prostate. Generally speaking, if you have a hard area on the prostate, or the prostate itself is hard all over, that is indication that there may be cancer in that prostate.
And then sometimes there is an enlarged prostate, but it doesn't necessarily mean cancer. And I do want you to speak quite a bit about that this evening too, because even though this is a prostate cancer program, there are people that have benign, maybe chronic, but relatively benign conditions of the prostate, and if we can talk through a couple of those.
Okay, to start out with, every man that has a prostate, that prostate, as we get older, grows. It may grow a little bit, it may grow a lot. Generally speaking, the more it grows, the more symptoms you can have. But you can have a very large prostate and have no symptoms, or you can have a very small prostate and have a lot of symptoms. You don't treat size, you treat symptoms.
Okay.
The other thing that's important is that, and this is something that people don't realize, because if you go to a laboratory, the laboratory will say your normal PSA is between 0 and 4. Okay, that's not true. Nowadays, when we screen patients with prostate cancer, Personally, I look for anybody who has a PSA above 1.5.
Above 1.5?
If their PSA is above
Okay.
1.5, I'm going to want to investigate them further. And if it's less than 1.5, you probably don't need to check their blood level for another 4 or 5 years.
Okay.
And that's something that's relatively new. It's been out since about 2015. Dr. Crawford put out a chart on that. And I have found, I mean, I was just talking to Dr. Mendel today. I sent him a patient that I checked his prostate and he had a small nodule, and I biopsied his prostate. His PSA was 1.
His PSA was 1?
1. And he had cancer.
Okay.
Which is the reason
Wow.
why it's so important to do both the blood test and do the rectal exam.
Right.
People always ask, gosh, if I have the blood test, why do you have to stick your finger up my derriere?
Yeah.
And that's why.
Well, yeah, absolutely. And so when you're talking about PSAs, and we're going to have all kinds of radiation questions in a moment, but when we're talking about PSAs, is the goal to have 0? Is that even a number that exists out there?
Only after they've been treated.
Okay.
And it doesn't go all the way down to 0, but it'll go down to 3 decimal points.
All right. All right.
But normally, if you have a prostate PSA, a lot of people, most people actually have PSAs less than 1.
Okay.
Okay. PSAs start rising as you get older, but as long as it doesn't get above 1.5, no matter what the age, I don't tend to get too concerned about it.
Okay.
Unless there's a family history of prostate cancer.
Now there used to be, and it's not called watchful waiting anymore. Is it surveillance?
Active surveillance.
Active surveillance. So talk about active surveillance. So we have a prostate, let's say we have a PSA, which is prostatic specific antigen, and let's say it's a 4.5. Digital rectal exam does not indicate that there's anything wrong. So when does a person go into the mode of active surveillance? And how active is that? Is that once every 6 months that they get checked again, once every year? How do you usually do that?
Active surveillance is decided based on the biopsy.
Okay.
If you have a biopsy and the biopsy shows 1, 2, or even 3 positive biopsies, and those biopsies are low-grade cancer, and we decide what low-grade cancer is based on what we call a Gleason score.
Yes. Okay.
Or they also call it a group grade, which is a little bit more confusing. But a Gleason score of 6, generally speaking, is the prostate cancer that you can put on active surveillance.
Okay.
Fortunately, we even have additional testing that we can do, but I'm not going to get into that because it's a little bit more complicated. But more often than not, people that have low Gleason scores and don't have a lot of cancer are people that you can put on active surveillance. And you can follow them every 4 to 6 months for many years.
And sometimes there's a person that I know that is, I think, in the 7th year of active surveillance, and for the most part, things have just stayed a little bit steady.
And you may go the rest of your life and never need anything done.
Yeah, excellent. Dr. Mendel, let's talk about you. There are so many, again, different options, and by the time you come into the picture, let's say that the options of surgery, which we are going to talk about specifically in a little bit, sometimes there's radiation first and then there's surgery. Radiation to bring tumors down, surgery, and then sometimes vice versa. So when you start coming into the picture, the biopsy's positive, we need to do some kind of radiation. I feel like there are so many different types of radiation, from beam to radiation seeds to just different types. And because you're 12 years old, you have studied all the new ones out there on the market.
That's going to stick, Travis.
I know it is. Look at them. But what is not most popular? What is most used now in the world of radiation, specifically for prostate cancer?
So basically, radiation for the past 30 years has been kind of a one-trick pony for prostate cancer, where you come in, you get 44 treatments, Monday through Friday for 20 minutes, you get a radiation treatment. And you do it 44 times. And the reason you do that is the thought is the cancer cells get damaged more than your normal tissue cells do. And the normal tissue is able to repair itself while the cancer dies. So you give a little bit so you can kind of recover from it, and it's a little bit more gentle. More recently, different regimens have been coming up and out, and it's been more to intensify treatment, because the 44 treatments, while it's the tried and true approach and what majority of people do, there's more convenient and sometimes more intense treatments that we can use for patients with higher risk disease.
Okay.
And so what Dr. Vogelweed was talking about, these Gleason scores, they play a very big role in kind of decision making in my field, because if you have your garden variety cancer, you know, they're going to respond well to basically anything you throw at it. But if you have a high risk patient who has either lymph nodes or like the possibility of having lymph nodes,
Right.
or high grade disease inside the prostate, it's more difficult to kill. And so we escalate treatment with either higher doses or with the brachytherapy.
So I'm going to go backwards a little bit to a somewhat basic question. So let's say that we've been talking about a cancer that is just in the prostate. And now let's talk about disease that has left the prostate, because you were talking about lymph nodes. So how does one screen for that? And let's say not screening. This is a person who has symptoms, they've come to see you, PSA is elevated, digital rectal exam is not good, you've taken a biopsy and now it's spread beyond the prostate. What is one of the most common ways that happens? And again, I know everybody's different, but what are some of the common treatments when the cancer is moved a little bit outside of the prostate?
Well, it can be, generally speaking, if the cancer is moved outside of the prostate, unless it's only the pelvic lymph nodes, then you can answer more to that.
Okay.
You know, you can treat it with either surgery or radiation. Surgery, when you actually take out the prostate, you can check those lymph nodes, remove them, and we do that pretty much on you know, a Gleason 7 cancer or higher. The second option, you can answer that better than I can as far as radiation is concerned. You can radiate the prostate and radiate the lymph nodes also.
Okay. So radiate the lymph nodes, but leaving the lymph nodes in.
And yes.
You're
Now,
not taking them out at this
taking it
point.
back a step,
Okay.
once you make the diagnosis, we do two things. We do a CT scan, and that will tell us whether there's lymph node involvement. And you can do a bone scan, because prostate cancer goes to the lymph nodes and it goes to
Right.
the bones.
Yes.
Okay. The problem is that you have to have 1 million cells before anything can be picked up. So none of these tests are absolute. And so no matter what you do, no matter what you throw at them, there are no guarantees. We wish
Right.
there were, but there are no guarantees. The good thing is that we're doing more and more and more research. We're trying to catch up with breast cancer. There's been so much done with breast cancer, and they know so much more about that. And we're trying to catch up and find out different treatments to prolong their survival.
And a lot of genealogy in that as well, right? There's more and more testing in prostate cancer in the world of male cancers, which...
Somewhere between 15% and 20% are hereditary cancers.
Okay,
Yeah.
that's a high number. So several years ago, I don't think we could have said that because we just didn't know.
Yeah.
Just
And
didn't
it's
know at that
associated
point.
with BRCA breast cancer,
Yes.
BRCA1 and BRCA2.
Okay.
Plus there are so many other
I remember
genetic
Dr.
variants.
Rivera talking about that, and I'm sure I'll be talking to her next month. She'll be on for breast cancer, and we do talk an awful lot about just genetics. And I look at the students when I think about gene therapy, and just because that is such a, it's not even new anymore. It's just something that everybody's getting taught in medical school. Dr. Mendal, if we can talk a little bit now about the lymph nodes, because now the prostate cancer has spread to the lymph nodes. You're treating both the prostate and the lymph nodes. Okay, my apologies. How many lymph nodes do we have in the groin area anyway?
A lot.
A lot. I know armpits,
lot.
groins, lymph nodes.
Yeah.
So, for example, breast cancer, there's the sentinel node. Is there anything like that in prostate cancer? Are there specific nodes that you're looking at or that the cancer would spread to first?
Absolutely. So,
Okay.
so basically, there's pathways for nodal drainage from every organ or every tissue site in the body, and essentially we've figured those out, and so we know which lymph node basins are going to be at highest risk for metastatic disease. And typically, if a patient comes in with high risk cancer, I'll cover the lymph nodes. It doesn't
Okay.
add much toxicity. It kind of gives you a little safety net, and it makes it to where you give them the best bang for their buck when they're getting their treatments. And so the way it works is you start off with a larger field of radiation and cover the lymph nodes and also the prostate and seminal vesicles. And then at the end of the treatments, you hone in on the prostate either with brachytherapy or more external beam, but it's more focused in on where we know the cancer is.
Okay.
And in the past, they used to just essentially draw fields on an X-ray and just, I guess plug the machine in and turn it on and blast away. But now we're a little bit more sophisticated. The field's kind of evolved with technology, and every year there's something new, a new technique. And specifically what I do is I try to eliminate as much sprayed dose or unnecessary dose to different organs in the body and focus the dose on where I know the cancer is. And so I look on the CT scan. We use a CT scan for planning, and I go through, and if I see a node that looks suspicious, I hit it with a much higher dose than just the general dose spread in the lymphatics. And so
now, when you say you hit it, and I'm interrupting you only because if you go further, then I'll forget to ask this question. Because of the 44 therapies, you were talking about that. So you are applying therapy, radiation therapy, on the patient who's there. Is that the same place then every time you do radiation from then on out? Does the machine lock in on this particular patient and know, okay, this is a place that we do that? That fascinates me, and I don't know how it works.
So basically, you have prostate cancer, you come in and get a CT scan. We call it a CT simulation, but it's basically a CT scan that we have a bean bag to basically index your body on the scan.
Okay.
The scan, we basically make like a coordinate system in your body, and that's how the machine knows what to target and what to do. And me and the dosimetrist go in and we draw out the areas that are at risk, and I map where I want the dose to go. High doses, low doses, it ends up becoming actually quite complicated. And then the dosimetrist and the physicist, they work to make sure that the radiation dose is being delivered to where I want it to be. And there's all kinds of tissue constraints and things you need to be careful about and stuff like that you learn in residency.
Right.
But in general, it's a very efficacious treatment, and patients tolerate it very well.
Okay.
And it's funny because patients come in, they hear radiation, and I swear it's like they just watched Chernobyl on HBO.
Right. That's why I wanted to get to that point.
Yeah, you can see it.
And I'm going to talk about, and Dr. Vogelweed, you hate this, but I have to talk about it. We need to talk about incontinence with surgery, and we need to talk about sex. We need to talk about impotence.
He does it too.
Okay, you do it too. I know.
He does it too.
But these are the questions that, and just through the years, if you're sitting in front of a patient, they're looking at you and you're a human being, and they may not ask the question. We're on TV. Again, it's live and you're anonymous. So call in with these questions. So let's talk about surgery real quick and the advances of surgery. So let's say 20 years ago, prostate cancer removal or any kind of surgery. So immediately the thought was incontinence, or the thought was, well, I'm going to be impotent. Very, very different today than it was years ago. So I would love for you to kind of walk through maybe a case study. We don't need to know their names or anything, of someone who was asking all these questions and you're trying to give them the reality of surgery.
Well, the reality is it's still a risk.
Yeah, well,
It's still a risk with radiation, and it's still a risk with surgery. One of the advances that about, and most people know about, is that now we have robotic surgery.
Yes.
And robotic surgery has decreased the risk of incontinence to some extent, has decreased the risk of impotence to some extent, because you have a better view of the prostate and the nerves that go around the prostate. But it's not a guarantee. You still have that risk, and it's still going to happen. I think 50% of radiation patients with just the standard IMRT have a risk of becoming incontinent. Impotent. It doesn't necessarily happen right away. I stand corrected if Dr. Mendel wants to correct me, because I don't know everything.
Yeah, you do.
No, I don't. Every time we make the diagnosis, no matter who the patient is, we have to inform them.
Absolutely.
We have to tell this is a risk. You have to say, you have a risk of incontinence, you have a risk of impotence. I'm sure that Travis does the same thing, Dr. Mendel. And then there are additional risks. Obviously, there's a risk of surgery. You can damage other organs, okay? There's a risk of radiation. You can zap other organs. All these things we try to bring down to a minimum risk, and are pretty successful at doing that. But it's always there.
It's always there.
Yeah.
And I'll ask the same question on the radiation side, because in my head, maybe I'm thinking about the old days, that's always one of the questions for the surgeons. So now we're talking radiology. And again, when you're looking at risk factors, you said specifically that you're looking at very targeted areas and very targeted beams, where 20 years ago it was just kind of like, well, let's just get everything in there. On that note, when you're getting questions from patients, how do you talk with them on what the risk factors are?
Yeah, so it's a very common question. Almost every patient that comes in, that's the first thing on their mind.
That's why we had to talk about it. You know,
Oh,
it's
yeah.
like, do we talk
Oh,
about
it's a
sex on
big
PBS?
topic.
Yes, we do. Do we talk about not being able to pee on PBS? Yes, we do. But it is. These are questions that people want to know. So what are the biggest fears, and what are your reactions to those?
So I think just erectile dysfunction in general, it's, you know, most guys feel that is losing their manhood. And so they're more concerned about that, honestly, than living sometimes. And so the way I explain it to them is for radiation, I kind of bend patients in 3 groups. And so, you know, 1/3 of patients are going to have, you know, essentially no side effects from the radiation treatments, and they're going to continue on their merry way. And maybe the normal aging process in ED happens a little faster, but they're still able to function, and, you know, things are fine.
Right.
And I've had those patients. I have another group of patients, another 1/3 of patients that will take a hit. They'll take a hit, but they can take Viagra, they can take Cialis, they can take some kind of medication that helps them, and then they're able to, you know, still have intercourse. They're still, you know, relatively normal.
Okay, so they take a hit, but there's still options. There are
Yes.
treatments for taking the hit.
There's
Okay.
medications.
Gotcha.
And then there's another group of patients, and these are usually the patients that are diabetic, which we have a lot of here in El Paso, or have other kind of comorbidities, vascular issues, things like that, that already have ED. Those patients will take a big hit, and there
Right.
won't be any medication that can help. And then in those situations, a lot of times we have the patient speak with the urologist about some kind of prosthetic device or something like that.
Okay.
But in general, I think radiation has evolved to the point where we're able to kind of shrink our volumes because we're more confident about what we're targeting. In the past, you know, people would use, you know, maybe a centimeter or more to target the prostate, because we have to take into account that it's an organ in the body that's moving, not where it's, you know, it's not always in the same spot at the same time. But now, you know, when I treat prostate cancer, I use an MRI. I make my margins very, very small, make sure that I'm trying to carve around the areas that are at risk for erectile dysfunction. And so in the past, Dr. Vogelweid's correct, where it's, you know, old radiation treatments, your erectile dysfunction is probably 50%, if not more, honestly. But now, I mean, I think we'll see in 10 years with my numbers, because I track them. But basically, I like carving around and protecting these areas that are at risk. I think it's going to help, and I think it's more like 30%, something like that. And it's basically dependent. A lot of it's dependent on kind of your you know, baseline issues already.
And I love that you say you're tracking them. So you're tracking the surgeries that you're doing, or not surgery, excuse me, the radiation that you're doing, and in general what the areas are. And again, that's why, and Dr. Vogelweid is probably tired of me saying this, but every single year there's something new that I've learned because of the tracking and everything that's going on. Question here from the audience, Dr. Vogelweid, I'm going to send this to you. 64-year-old male with an enlarged prostate. What are the chances that the bladder can be affected with a large prostate, and should this be checked? So in the old days, these were the cards that the medical students used to run to me. Now they're texting them to me. So that's all the information that we have on this question. So when I say that, that's kind of the disclaimer of we answer it to the best of our ability with what information that we have. So again, the question, yes, enlarged prostate, wants to know if this will affect the bladder. And is that a question that occurs often?
No.
Okay.
But I'll answer it anyway.
Okay.
Anytime your prostate's enlarged, it can impinge on the bladder.
Makes sense.
And you know, one of the most common symptoms of an enlarged prostate is urinary frequency. You urinate more often, you have a weaker stream, you've got to go, you get urgency. Prostate cancer can also grow into the bladder. And that in itself is another problem, because if it grows, it can actually grow into the ureters that are coming into the bladder and block the ureters. And that, of course, is more advanced, more aggressive disease, but it can still have the same symptoms, but it also can make your kidneys fail if it advances far enough.
See, it would be nice. I feel like every time I have you on, it's associated with cancer. I would love to have a urology show that isn't associated with cancer and talk about all those kinds of issues, because there are so many issues, right?
Yes. Kidney stones.
Oh gosh.
Enlarged prostate.
And then you have us
of
girls
other parts
too. Us girls have all kinds of urology problems too. That would be a show I want to do. I am going to, actually, I'm going to throw this out so whoever wants this one. Again, this is another question from the audience. We talked about active surveillance. How often do you need to get your PSA and biopsy done if you have had a PSA of 3 to 4 that stays that way for years and the cancer hasn't grown and the biopsy was minor? I know that it's a kind of a complicated question that goes back and forth, but bottom line is, we were talking a little bit about that. PSA is between 3 and 4, biopsy stays the same. They're asking how often should they get checked?
Okay, it's a good question, okay? But let's just assume that the PSA was 6 when you made the diagnosis, okay? The PSA is variable, okay? Obviously, if you're gonna have a PSA of 15, you're really a lot more concerned than that. You may have missed a cancer. But if you're on active surveillance, the first thing you do is, you make the diagnosis, you make sure that you're comfortable with the active surveillance, and then the standard of care is to repeat the biopsies in a year no matter what, even if the PSA doesn't change. After that, it just depends on what the PSA does. If the PSA continues to rise, you can either repeat a biopsy or you can order an MRI and see if there's a suspicious focus. And even if that turns out negative, you can do something that's called saturation biopsies. You take them to the hospital and you do about 30 to 36 biopsies of the prostate. And a lot of times you pick up cancers that otherwise you miss.
Interesting, right. And that makes sense too. I'm going to leave the audience for a minute because we've got a couple of more there. I want to talk about brachytherapy, if I'm saying that right.
Yes.
Because I feel like that is what's been talked about over the last decade, but really last 5 years. I feel like I've heard a lot more about that. So explain to the audience what that is.
So basically, brachytherapy is when we either put a device inside or catheters and treat with radiation from the inside out. And so brachytherapy is using like metallic radioactive pieces of metal to treat the prostate or other malignancies as well. And so
that stay inside the prostate.
So some of them do. So there's the prostate seeds that I'm sure everyone's heard of.
Yes.
Those are permanent seeds that go inside the prostate and stay there permanently. They decay, they release radiation, and it's a very effective way of treating prostate cancer. It's usually used as just a monotherapy, just seeds alone for low risk and kind of, favorable intermediate risk patients, so kind of lower risk patients.
Okay.
They can just do that alone and they have a great outcome. We actually at our center we do HDR where we actually put catheters in, and then essentially a radioactive piece of metal on a string goes inside the catheter, stays in there for a couple of seconds and delivers radiation and then comes out. And it goes into each catheter, and then you take everything out and the patient goes home. They're not radioactive. That's it.
So what are you using to get inside the body? Are you using a sonogram to know exactly where you need to go?
Yeah, we
so
use,
it's an active, go ahead, sorry.
Exactly.
Okay.
So we use an ultrasound.
Okay.
And so the ultrasound allows us to guide the needles to where they need to be and not puncture the bowel or the bladder or everything like that. It's very labor intensive and requires a lot of skill. And so kind of the way it's been evolving in the US is, people have been moving away from this because it takes a lot of time, effort, it's a little bit more risky, but the outcomes are, they're very good. And it's been around for a long time. And so it's very important to make sure people are aware of these techniques because a lot of practitioners, they won't do them because it's just difficult.
So if this is one patient, how often would one patient have that done?
I'd say it's very rare.
Okay.
Yeah, very rare nowadays.
So if they have it once, in other words, would they have it again, or is it once and done?
It's usually once and done.
Interesting.
I will
Okay.
say this, with the HDR, another way of utilizing it is for patients who fail their treatments. So if
Okay.
you had radiation 10 years ago and now you have a local recurrence either in the seminal vesicles, which are these little structures behind the prostate, or inside the prostate, you can deliver radiation focally with catheters, brachytherapy, to salvage that situation, and it works like 60% of the time. So it's a pretty effective way of fixing the situation.
It is. While I have you on the chair, IMRT, so this is intensity modulated radiation therapy. What is that compared to what you're talking about?
So IMRT is just a technique So inside the machine there's a large gantry, and inside that the radiation basically comes out. It's just X-rays. That's all it is.
Oh.
Like a chest X-ray or a CT scan, it's X-rays that come out of the machine head. Inside the head there's these things called MLCs. They're basically these metal leaves that move in and out. If people can see, they move in and out like this, and they modulate the beam. And so if there's a structure in the way or that needs to be avoided, you're able to kind of modulate the beam around that structure, so that, for example, on prostate, the rectum is one of the structures that we're trying to avoid.
Right.
And so we use IMRT to avoid the rectum or avoid too much dose to the rectum so we don't damage it, and then make sure the majority of the dose is going kind of focusing in on the prostate.
Okay.
So IMRT is a technique to do that. The other type is called 3D, where you basically just point and shoot, and the beam comes out. You can kind of modify it a little bit, but it comes out just how it is, and there's a lot of hot
full
spots.
strength, full.
Exactly.
Okay.
Yeah.
And how often is that being used now in this day and age?
It's used very frequently actually in breast cancer.
Okay.
It's a great. It has its place. Not many people are using IMRT for breast cancer, but just the 3D technique, just to kind of graze off the chest wall, it prevents unnecessary dose to the rest of the body, and it's been a very effective technique, and not many people have really moved away from that. But for IMRT for prostate, no one uses 3D.
Interesting.
No one anymore.
Okay.
Well, I'm sure there are people, but
for the most part,
they
it's
shouldn't
not
be
a
using it
practice
anymore.
that's being
Yeah.
used anymore. Interesting. Okay, because I have here like 5 questions on IMRT, but I think you handled every single one of them. I'd like to go back now and talk about surgery, and when is it necessary to actually remove the entire prostate? And when that is the case, what is the gentleman looking at going forward in life? And let's say it's someone, let's go with a young person. Let's say it's someone who's 65, and it's just time that the entire prostate's to be removed. They're asking you, okay, so what does that mean after my surgery? What's the recovery time, etc. Take that. I know it's a huge, broad question. It is, but it's a big one. That's one that's out there.
Well, when you're treating cancer, you take out the entire gland.
Okay, so all the time you take out the entire gland.
If you're going to do surgery, yes.
Aha.
There is such a thing as focal therapy, and there's a lot of research being done on focal therapy, either with high-frequency ultrasound or cryosurgery. The problem with high-frequency ultrasound and cryosurgery is prostate cancer tends to be multifocal. And in different areas of the prostate, you can have a less aggressive or more aggressive cancer. And you can't always identify the exact area where those cancers are at. Although, you use a template, like you can use a template, and you can get very, very close biopsies of the entire prostate, which is very labor intensive. And it's done more in research centers. But when you are treating the cancer, you take the prostate out.
Okay.
It's usually nowadays it's done it's a robotic surgery. You're usually in the hospital for 24 hours. You're usually wearing a catheter after surgery for 1 to 2 weeks, depending on surgical preference. Recovery is quicker. The patient does better with robotic surgery, but it takes a while to heal, just like anything else. And usually you're not ready to go back to normal physical activity until 4 to 6 weeks after.
Okay.
Although I've heard of people swinging a golf club 3 weeks after.
Yeah, that's a little scary. Don't do that. When I say that, it's like follow doctor's orders. Question here from the audience, and I have not heard of this before, so pardon my ignorance on this. A man called in with an enlarged prostate and is wondering if prostate artery embolization is effective. I don't know what that is. Again, this is all that we have. If we can't answer the question, we can't answer the question. But again, prostate artery embolization, what is it, number one?
They've been using it for treatment for BPH or an enlarged prostate. It's not an effective treatment one way or the other. It can shrink. I mean, you cut off the blood supply, you shrink the prostate. Okay?
Oh.
It's as simple as that.
Okay.
Is that a good
like
primary
ablating
treatment for enlarged? I mean, we have for BPH, for an enlarged prostate, we have so many different treatments nowadays. The standard of care is a transurethral resection of the prostate, or TURP. But, we have Urolift, which is basically squeezing the prostate with stitches. We have Resume, which is basically injecting steam into the prostate and cooking it. We have laser prostatectomies, where you just vaporize the prostate from the inside. there's a lot of different treatments, and it really depends on the individual situation and individual preference.
I am, again, typing into some of the questions. When we're talking about the different preferences, and I want to, actually I'm going to go to Dr. Mendel first on this question, because again, radiation, there's so many different options. If you were talking about the 1/3, 1/3, 1/3 earlier of what happens after different types of treatment. So let's say that there is one guy, he's the same 65-year-old guy that we had. He doesn't want to have his prostate removed, so now he is opting for some kind of radiation treatment. What options, and I know I'm not giving Gleason scores or anything like that, just some options, and I know we've talked a little bit more, but just the most common things that you're doing right now. He's 65, super young, should probably have the prostate out, but doesn't want to, so he's going to the young kid over here that does radiation. What do you tell him?
So basically, when patients come, I have essentially a PowerPoint presentation that I can show them. And prostate cancer, it's been studied that compared to surgery and radiation and active surveillance, if you compare radiation and surgery, the outcomes are the same. The lines are right on top of each other. And this is specifically for low risk and intermediate risk, like favorable prostate cancers. The outcomes are the same. And so we have a lot of techniques nowadays to treat prostate cancer, and it's very specific to the situation. And so, like I said before, the most common treatment is the 44 treatments, but nowadays people are moving, sometimes to 20 treatments,
right,
which is more convenient for the patient. It may be a better treatment actually. And as the technology has evolved, now we're able to do it in 5 treatments. And so it's called SBRT,
wow,
it's stereotactic
from
treatments.
44 to 22 to 5.
Yeah, so now we can do it in 5 treatments, but it's very specific. The doses are higher, it's a little bit more risky, but it's certainly more convenient. And here it's going to blossom because there's a lot of patients that have to travel a very far, long distance to get these treatments.
Right.
And so if they can get it done, more effectively financially for them, or if the distance is an issue, it's a great treatment option for them. But again, it's very situational.
It's very situational.
Yeah.
And like you said, I remember the days too when we used to tout that the decision of what you're going to do for treatment, you take the whole family in there because everyone has to figure out who's doing what. Another question here from the audience, does saw palmetto help with prostate? Don't know what that is?
I certainly do, yes.
Okay, all right.
Saw palmetto's been around for many, 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 many years.
Okay.
And if you put a sugar pill right here and saw palmetto right here, they're both equally effective.
Gotcha.
Okay.
Okay. I like how just direct you are. Same thought process here. Question from the audience is taking cranberry extract supplements help with urinary health? So not talk about cancer, but with urinary help in general. And I've heard that too, cranberry juice. Is that a thing?
Yes.
Okay, tell us why.
I don't know. Supposedly because it acidifies the urine, it makes it less likely for you, for people to get recurrent bladder infections. And the pill is equally effective as the juice because it's a concentrate.
So could it be other juices
Do I use
as well?
it? No, I don't, not usually. But a lot of people do, and they say, oh, I'm taking cranberry. Good for you.
Good for you. If it's something you think will help, that's always the way it works here.
So I've actually heard that the cranberries, they apparently inhibit the ability for the bacteria to adhere to the mucosa in the
So if you're looking for
tract.
any urinary tract type infections, that's what. So say that again. It inhibits the bacteria.
So the bacteria aren't able to actually adhere to the
mucosa.
The mucosa.
Okay.
That's supposedly how it works. And then the cranberry juice, it's actually the cranberry, like taking cranberry extract, because apparently the cranberry juice, especially if you go get Minute Maid or something like that, it's essentially all sugar and no juice and hardly any cranberry. It's just flavored.
Right.
So that's probably not the most effective way of dealing with it. But the cranberry extract, where you can get a high concentration of it, that's probably, technically more effective. I don't have any data to support this, though. I've just read about it because I was interested one time.
So I am Dr. Vogelweed, I'm going to show this to you. There's a name here, Dr. Chesbrough. I try to keep questions from past shows on the same topic. And Dr. Chesbrough was kind of our chemotherapy guy, so to speak. And at the time, this was several years ago, when there was an anti-androgen therapy. I remember us talking a little bit about it. I know that you're not a chemotherapy guy, radiation. Is that something that is being used anymore? I feel like I haven't heard a lot about it lately.
That's an excellent question.
Oh.
I'm glad you brought it up.
Oh, good.
Because,
Okay.
you know, it used to be that, you know, prostate cancer, you can't always cure it, okay? And if you can't cure it either with radiation therapy or surgery, or if when you get the patient to start out with the cat's out of the bag, well, then what do you do next? Well, the standard of care for many, many years used to be androgen deprivation. You basically block their male hormone, and that stops the growth of the cancer.
That's what I was going to ask here, hormone therapy. So that basically is the hormone therapy.
And that can either be done by, now we have medications that block the pituitary. They have medications that stimulate the pituitary with the same effect, that completely blocks the male hormone. But even that, cancer cells are very smart cells, and they can fight anything. And they can come up with new ways of fighting the cancer. And so, you know, the last 5 or 10 years have really revolutionized the way we treat these patients with prostate cancer. And that's why in my group, we actually have a segment that treats these patients that have advanced prostate cancer. And you have androgen blockade, you have androgen receptor blockade, you have medications that actually stop the production of androgens. They're all made from cholesterol. You can block the production of the androgens. We have immunotherapy to treat prostate.
Yes, we didn't even talk about that.
And I'm missing something. Well, obviously you have chemotherapy.
Right. And chemotherapy doesn't seem to be a therapy that is often associated with prostate cancer. I feel like it's surgery, it's radiation, and every now and again, if there is a metastasis, there's chemotherapy involved. Am I wrong with
Chemotherapy
that,
chemotherapy was actually the first thing that was tried.
Okay.
After, you know, once you put them on androgen blockade and they no longer respond, the next thing they did was chemotherapy. Chemotherapy is harsh in most circumstances, and so we've always been looking for other ways of treating the prostate cancer that aren't as harsh.
Okay.
And there are a lot of medications, and there are actually different stages and different kinds of medications for those stages. Like if you have a patient that presents and he has advanced disease, but he's never been treated, you can give him the androgen, you can block the male hormone, plus you can give him another type of medication that either blocks the synthesis or blocks the receptors of the androgen in the cancer cell. Okay, well, there's some medications that are approved for that. There are other medications that are approved for if the patient has already, his PSA starts rising after he's been treated with with androgen blockade. But they have no evidence of metastatic disease, they have another group of medications for that. If they do have metastatic disease, they have another group of medications for that.
Right.
And it becomes more and more complicated. But a lot of these things, and then we're starting to get into other forms of therapy, like immunotherapy. We're using PARP inhibitors, which are used a lot for breast cancer.
See, this is where we've got like 7 minutes left, but that's what we need to talk about too next time. In fact, I'm going to make that one of my, for the next time we do that. On that note, since we have 7 minutes, I'm going to stop any questions from myself in the audience right now, and I want you to talk about something, or we can continue on that we haven't covered yet tonight, or something you just want to get across tonight that, you know, before the show wraps up, you know how quickly that happens.
I sort of want to do a little bit of a variation of that because, as I told you earlier, I run an advanced prostate cancer clinic, and usually when these people start their prostate cancer advances, my partners send those patients to me. Some of these patients I use Travis's help, because if they have, you know, like they have a lot of bone pain and they have a metastasis to one of their bones, he can treat that and he can get rid of that pain. It's palliative, but it actually helps the patient.
Right.
But the message that needs to go out as far as that's concerned is that we can give these patients more time, and we can give these patients more quality time.
Exactly.
and it tends to be a sequential treatment. Like if they come in, we can give them usually these patients have either been on Lupron or they've been on some other kind of medication that blocks their male hormone, and it's no longer working. And so then we can give them an androgen receptor blocker or an androgen synthesis blocker. I know these are confusing terms, but then we can also give them actually the next step is supposed to be immunotherapy, where we actually take the patient's patient's white blood cells out of his body, and then we send those to Atlanta. They treat those cells and teach them how to fight the cancer. And they bring those cells and give them back to the same patient 3 days later. Okay, it doesn't affect the PSA, but in these patients that are in good, they're still in good performance status, they can give them up to 12 to 14 months of additional time.
So it does not affect the PSA.
No,
but
it does affect long-term survival.
Interesting, and it's and I feel like that is not the wave of the future. It's happening right now, but there's more and more information and research.
Every single day.
And so 3 days, that's gone, comes back 3 days, and it starts building up your system more and more.
Well,
and more.
it's actually 3 treatments 2 weeks apart.
3 treatments
you do it
2 weeks
3 times.
apart.
Yeah.
Okay. And then usually, let's say that person has gone for a year, could they redo that treatment again?
No, they're not
Okay.
approved for that.
Okay.
But if they have cancer in the bones, we have radium-223, which Dr. Mendel can tell you a little bit about.
Okay, go. Radium-223, do it.
So this is a form of injectable, like liquid radiation that hones to the bones and is used to treat patients who have, mini bone metastasis. And to kind of build on what Dr. Vogelweed was talking about in his clinic, radiation, there used to just be patients who have a localized prostate cancer and metastatic prostate cancer. But now we're kind of figuring out that patients that have what's called oligometastatic cancer, just several lesions in the bones or somewhere else, this is a different state that's differentiated from patients who have numerous lesions that you can't target. And so now the field's kind of moving towards treating these lesions, these 2, 3, 4, 5 lesions in the bones, in the lung, in the liver, and all different cancer sites. And we're finding that treating these lesions is improving patient survival. And so this is something that I think is going to be very, we're going to be talking to each other a bunch because this is a state that people are now realizing, and it's coming out just in very recent papers in the last 2 or 3 years that this is an effective treatment. So
next year's show is going to let's focus on that too. So explain to me when you say liquid radiation, my head is thinking, okay, you're injecting radiation and it's going everywhere. That's not the case, right? What does that mean? How are you distributing the liquid radiation?
So it basically comes in a syringe. We order it, and it has a certain half-life, and so how long that the fluid is active.
Okay.
But basically, it's radium-223 that's been dissolved in a fluid. You inject it just like you start an IV. I walk in the room. There's a syringe there, and I inject it into the patient's arm. And it's all weight-based, but basically it travels.
And it knows where to go.
Well, it travels to the bones. For whatever reason, this likes to go to the bones, and that's where the prostate cancer likes to go. And so it goes there and it treats those areas, and it's very effective for patients who have multiple lesions. We can use external beam too if they're having focal areas of pain, but this is actually, the radium-223 was shown to actually have a survival benefit in patients, and this is specifically for patients who are castrate resistant.
And bone cancer, once the cancer gets to the bones, it's painful. So that really helps too with palliative care.
Exactly.
It can be painful.
It can, okay.
It can be, because some people have mets all over the place and then not having a lot of pain. Radium-223, radium is in the same column as calcium.
Okay.
Okay, in the periodic table of elements. And so the cells that build up the bone can grab that radium instead of calcium, and that's how and then once they pick it up, it's right next to the cancer cells that are destroying bone. And it's a very, 2 or 3 millimeter penetration.
Yeah, it's very,
and
very,
so
very
that's why
distance.
even though you get it, it doesn't have this effect that it's going to affect the rest of the family when you get home.
Right. You're not
And
radioactive,
very
as
tolerable
you said earlier.
too.
2 quick questions from the audience. We've got 3 minutes, which is forever. Question is there a risk of prostate cancer with testosterone replacement therapy? Again, that's all we know. That's as basic as the question is. I'm throwing that your way.
it doesn't, you know, testosterone therapy, replacement therapy, if it's done properly, it doesn't have anything to do with prostate cancer. Okay.
Right, and I think that what happened, they were listening to hormone therapy.
But
later.
if you have prostate cancer,
Don't do testosterone.
do not do testosterone, because that, you know, prostate cancer feeds on that testosterone.
Right, which makes sense. Another quick question, K4 exam. What is the credibility of a K4 exam? Checks for genetic inclination. Question from the audience.
It's a 4K exam.
4K.
There are about 4 different exams. If a patient comes in and let's just say he has a PSA of 2.5, to me that sort of says, well, I have to look at this guy a little bit more in depth. So I'm not going to take him directly to a biopsy, but there's several exams. I mean, there's a PHI score, there's a 4K score, there's a PCA3, and the one that I use, which is now I've got a mental block, but basically what it is a urine test. Mm-hmm. And what they do is they tell you whether or not there is a risk for prostate cancer. Mm. Yeah, Select MDX is the one I use.
So that can tell if you have a risk.
Yeah,
of prostate
if it comes
cancer.
back and it says there's a risk of prostate cancer, then you take them and you do a biopsy. If they say there's a very low risk, then you just watch the PSA.
I did not realize that was out there, just the idea of having the risk. I stayed away from screening tonight, but we have 2 minutes to go. Just throw out there really quickly what the screening guidelines are, at least today.
Today, I encourage every single family practitioner, primary care physician, to screen any patient over the age of 50 for prostate cancer, okay, by doing a PSA and a rectal exam. And if they're black or if they have a family history starting at 40 or 45, all you have to do is do a PSA. If that PSA comes back as 0.7, they don't have to repeat it for 5 years.
Exactly. Now, I wanted to get that in because I feel like those have changed every year, and that's always like the first 20 minutes of discussion, so I wanted to kind of get that in. So again, 50 and over, definitely go get your PSA and digital rectal exam. Family physician, they can do that for you there. I want to say thank you very much to Rio Grande Urology. Nice to have you guys here. And if you want to see this show again, you can find it at www.pbselpaso.org, or you can also go to the El Paso County Medical Society website, which is epmcs.com. And also, this has been on YouTube, so you will be able to find this on YouTube again. Just type in El Paso Physician and look in prostate cancer, and you'll find this show and all the other shows that we've done as well. I want to say again, very much thank you to Dr. Vogelweed. Thank you for Dr. Mendel. Isa, thank you very much. And Ritaka, thank you very much. Those are our 2 second-year medical students who have been helping us out a lot tonight. And there's a lot of dings going on my phone, so I appreciate that. I'm Catherine Berg, and you've been watching the El Paso Physician.
Is known can help your peace of mind and your family's confidence in following your decisions. Do your loved ones a big favor. Make a plan. We're